All right. Well, thank you everyone for joining us for our Department of Medicine Grand Rounds. And we are extra excited today to be showcasing our incredible residents. Today hosting, I want to hand off to our fantastic internal medicine residency research chiefs, Anne Marie and Dylan.
Thank you. Hi, all, and welcome to Resident Research Day 2025. Today is our annual opportunity to showcase our internal medicine residents' research endeavors. It's no easy task to balance rigorous clinical training with great scholarly work, but our residents continue to go well above and beyond. We are so excited to celebrate their work and the mentorship from our incredible faculty who help make it possible. One announcement before we begin, please join us as Resident Research Day continues after today's grand rounds during our poster session from 4 to 6 p.m. in the Emory School of Medicine lobby, where we will be giving out awards for the best original research and clinical vignette posters. Stop by to see our residents' tremendous scholarly output of over 100 projects. I'd like to invite Dr. Del Rio up to the podium to make a few comments before we begin.
Thank you, and good afternoon, everybody. It's really a pleasure to be here today and to have our residents present their research. This is, part of what you do in residency is not only do you learn how to take care of patients, but you learn how to integrate, how to ask questions, how to ask relevant research questions. And you may, in the future, may be a researcher, you may not be a researcher, but that way of approaching a clinical problem, a problem that you face in the clinic and the hospital by thinking scholarly about it is really what distinguishes, academic physicians from a physician who's done in academic medicine. So, but I think that those skills are useful no matter what you do in the future because it helps you better read an article. It helps you better understand the literature, understand the limitations. But more importantly, I really still think it makes you a better clinician because you think about problems in a different way. You think about them, you ask the why question. I think asking the why question is something that always leads to really fascinating answers. So I'm really looking forward to hear today's presentations, to see the posters, and I'm particularly looking forward to hear our keynote speaker, Sara Turbow. Sara, I've known Sara since she was a medical student here, a residency here, and I've really seen her develop and become just a fantastic faculty member. And I think Sara can tell you that when she was in residency, she had no idea what she was going to do and what she was going to end up doing. But I think it was that finding your path, finding your passion, and pursuing it is really what got her to where she's at right now. So I'm really looking forward to hearing your talk. Thank you very much.
Thanks so much, Dr. Del Rio. So now, on to our presenters. We'll begin with our keynote speaker, as selected by the Resident Research Day Committee, Dr. Sara Turbow. And after her presentation, we will introduce our three resident speakers. Just to note, we'll be saving all questions for all four speakers until the end of the hour. So without further ado, it's my pleasure to introduce Dr. Sara Turbow. Dr. Turbow is an associate professor of medicine and preventive medicine in the Emory School of Medicine. She's an Emory lifer, as was mentioned, having completed her medical school, Masters of Public Health, internal medicine residency, and preventive medicine residency training here before joining the faculty in 2015. As a faculty member, she serves as the program director of Emory's Public Health and General Preventive Medicine Residency and Fellowship Program. Her clinical duties are in the Grady General Internal Medicine Division, where she serves as a primary care preceptor. Dr. Turbow's research focuses on healthcare outcomes associated with fragmented interhospital care for patients suffering from Alzheimer's dementia and related dementias. Through her K23 from the National Institute on Aging, Dr. Turbow examines the mechanisms that lead to increases in fragmented care for these vulnerable patients, as well as the associated increases in healthcare resource utilization. Her goal is to leverage the use of health information exchange networks and the expertise of health professionals and health systems leaders to facilitate the flow of information between hospital visits and reduce critical outcomes such as mortality, length of stay, and hospital readmission. We selected Dr. Turbow to be our Resident Research Day keynote speaker, not only for her impressive research and leadership in this field, but also as someone who has walked in our footsteps as Emory residents. and was inspired by her experience to take an issue she encountered in the care of her patients and study it with the aspiration to make systems level improvements. Thanks so much for being here, Dr. Turbow, and we look forward to your talk entitled From Scratch to Success, a Recipe for a Career in Research and Medicine.
Thank you all so much. Can everybody hear me okay? Fantastic. So yeah, thank you so much. I promise that Dr. Del Rio and I did not discuss that intro first, but he really encapsulated kind of a lot of what I'm going to talk about today. And thank you guys so much for that introduction, for having me. I am really excited to be here for all the reasons you mentioned. I have been in your shoes. I know what it's like to be an Emory IM resident. And I hope that I can impart some lessons that I've learned along the way and can inspire you to pursue your own research ideas. So as I was thinking, about this presentation, there we go. And reflecting on my path in research, I had a brainstorm while I was cooking dinner that cooking and research have a ton in common. I love cooking and baking. These are some pictures of me cooking and baking over the years with my son. And I definitely won't say I'm the best at it. You're not going to see me on Bake Off anytime soon, but I really enjoy it. And I think that cooking and research share the need for the right ingredients, and you have to follow certain steps. But you also need to be a little bit brave and be willing to try things and experiment in ways you haven't before. And if you're like me, what you try might not always work out, but you will definitely learn something along the way and hopefully have some fun. So today I'm going to share with you my recipe for research. And like I said, hopefully impart some lessons and inspiration along the way. So just like a recipe, a research career requires the right ingredients and the right amounts. So for me, that was my training in medicine and epidemiology, finding inspiration from a variety of resources, recognizing opportunities and sometimes the need to pivot, my mentors and supportive work environment, and of course, my support system outside of work. So an additional ingredient that I want to mention is that I grew up in a very science-oriented family. Here's a picture of me when I was 6 years old at the NIH. This is actually at the NIH Visitor Center. So because of my exposure to science and medicine as a kid, I knew that I wanted research to be part of my career. I just wasn't sure sort of in what quantity and what exactly form that was going to take. So the next ingredients were my training and skills and my sources of inspiration. So I came to medical school at Emory and got my MPH in epidemiology. And then, as was mentioned, I stayed here for internal medicine residency. When I came to medical school here at Emory, I actually was interested in infectious disease and global health. My life plan was to go work at CDC and hunt emerging infectious diseases. Obviously, did not end up doing that. But after doing my M3 rotations, I actually really fell in love with primary care, and my interests migrated more towards obesity and nutrition. So I just want to highlight, you might recognize Dr. Jennifer Brandt here. This is actually us during our white coat ceremony as M1s. And then this is me on match day with two of my close friends. So I decided to pursue my MPH in epidemiology here at Emory because I knew that it would give me skills that I could apply to kind of any area that I wanted to pursue. So while in my MPH, I was able to explore my interest in nutrition and obesity through my MPH thesis, which was published in the Journal of Nutrition. This was really my first experience taking a project from beginning to end, which was critical. And then also was my first exposure to secondary data analysis, which is really the bulk of what I do now. So this was a very formative experience for me. Also pivotal to my career was this article that came out in the second half of my MPH. It was called The Hotspotters by Atul Gawande. This was published in the New Yorker. So if you guys haven't read this article, I highly recommend that you do. It's still incredible. It highlights the story of a family medicine physician named Jeff Brenner in Camden, New Jersey. And he noticed that a very small number of his patients were using excess healthcare resources. And what he actually did was sit down and map them. And he found that they were clustered in certain neighborhoods. Then what he did, which I think was the most critical, was he started talking to them and asked them, what are the reasons that, you know, you're coming to the ER all the time? What are the reasons you're getting admitted? And that led him to better understand what their social and structural determinants of health were. And he worked with them to address those and reduce their utilization. So after reading this paper, I felt so inspired to try to bring this work to Grady. I approached Maura George and Hani Atala, who was an EM physician here at the time, and I shared this idea, and luckily they were both very supportive. They helped me get IRB approval and Grady ROC approval, got me connected to the right people to actually get data about patients that were coming to the ED. And then I was able to use my epidemiology skills to sort of identify that cohort of high utilizers to begin to understand who these patients were at Grady. So these two experiences are the beginning of my research career. Never before this had I had a topic that I was so excited about, that I wanted to spend my free time working on. And I also finally had the skills to actually, you know, make that topic a reality for me. So after finishing medical school, I stayed here at Emory for my residency in internal medicine and primary care. So here in the bottom is my graduating class with Dr. Higgins and Dr. Fluker. As you guys know, there's not a lot of time for research and residency. So my main focus was really just to become the best physician I could be and try to keep a toe in so I didn't forget everything that I had learned during my MPH and during medical school. So after finishing residency, I joined the faculty in the Division of General Internal Medicine here at Emory at Grady. And at that point, I was really ready to invest time in research. You know, as faculty compared to being a resident, I had a lot more flexibility. I had more resources at my disposal. But when I looked around and saw what was being funded and what was being published about high utilizers, the field was moving so fast and frankly had moved past me. People were developing and publishing interventions to try to combat high utilization. And I felt like we had not done enough to establish the epidemiology of the population, their risk factors, what the outcomes we should be examining were. And so at first, I still kind of tried to chip away at my little corner of this field. And I was really fortunate during this time to work with a couple of fantastic MPH students, Julia, whose article is at the top, and Damilola, whose article is in the middle. So we were able to get some of these projects done. I did get some funding from the John A. Hartford Foundation to do a pilot intervention that was focused on trying to see if a better medication reconciliation at discharge could prevent readmission in older adult high utilizers at Grady. But I still really felt that, you know, what I was seeing published and what was being funded was not really where I wanted to go with this research. So I took a step back and I looked around and I thought about what I was seeing in the hospital and in the clinics. And the one thing that had always kind of really bothered me about high utilizers research was that if a patient is coming to your hospital 3, 5, 10 times a year, they're probably not only coming to your hospital, right? But a lot of the studies were based at a single institution. And then also thinking about my residency experience, you know, I can't tell you how many times I was on wards at Grady and had to phone a friend at the VA, you know, to get more information. I also had a very memorable patient who was discharged from Midtown and literally walked to Grady to get readmitted. And so all of these experiences and sort of this nagging feeling about the high utilizer space led me to identify that, you know, I needed to shift my focus, and really led me to shift my focus to care fragmentation. And so I do really want to highlight that recognizing opportunities and going for them, to me, has been one of the kind of secret ingredients to my research career, to what I would call progress and happiness in my research career. And I really, really hope that if nothing else, that you leave this talk today feeling emboldened to look for opportunities and to grab them when you find them. So once I began to think and read about care fragmentation, I realized that there actually wasn't a ton of research being done on this area, particularly interhospital care fragmentation, which is when a patient is admitted to one hospital and then readmitted somewhere else. So This represented an awesome opportunity to innovate and to start down a new research path. But it was also a little scary because there really wasn't anybody at Emory who was working in this specific area at the time. So this is the most complex part of my recipe, but I wanted to go into a little more depth on these steps that I took and acknowledging that they're really not in order. Many of them kind of happen simultaneously or in fits and starts to show how I was able to forge my own path in research here at Emory. So first, I really needed to get a handle on what was being done in this space. Thanks to the suggestion of one of my mentors, Kimberly Rask, I formalized my sometimes chaotic PubMed searching into a systematic review. I was fortunate to work with a primary care resident on this, Katie Snow, and with Carla Galaviz from Rollins on this paper. I cannot tell you how helpful doing this was. Not only was it helpful to just kind of do a systematic review, learn the process, but taking this opportunity to dive deep into the literature has made writing subsequent papers and grants so much easier because now I know the literature cold. And then going through this also allowed me to identify additional strengths and weaknesses of the field and gave me a lot of inspiration for new ideas. So next up was building my mentor team. This is far from an exhaustive list, but every single one of these people has been so important to my research development, not just in terms of actually helping me do research or guiding me in career decisions, but also in terms of sponsorship, in terms of sharing opportunities, and in terms of pushing when needed. And so for those of you in the audience, for those of you on Zoom who are residents, you probably have heard this before, but your mentor team is absolutely critical to your success. So alongside the prior steps, I was thinking a lot about kind of where I wanted to take this research topic and what questions I wanted to answer. So initially I kind of went in two directions. The first was trying to think about how to expand how we think about fragmented readmissions beyond just a pair of hospitals. So if you think about Atlanta, right, we don't live in a place with just two hospitals. We live in a place with like dozens of hospitals, and you can bet that all of them are sharing patients all of the time. So this paper, one at the bottom, Association of Distance Between Hospitals and Volume of Shared Admissions, used data from several states to examine how the distance between two hospitals is associated with how many patients they share, with the hope that to kind of begin to create a case for information sharing between hospitals. The other direction I wanted to focus on was honing in on a specific population. So in my case, older adults with Alzheimer's disease and other related dementias. I've always enjoyed working with older adults in the clinic. And as I mentioned, I previously had that funding from the John A. Hartford Foundation to do the intervention on older adult high utilizers. So this felt like a natural fit. I also hypothesized that patients with cognitive impairment might suffer more from fragmented care than patients without cognitive impairment due to challenges transmitting their health information. And this challenge could potentially be mitigated by health information technology like health information exchanges. So with this focus, I successfully applied for a K23 award from the National Institute on Aging. For those of you who are not familiar, a K award is a career development award that ideally supports your progression from kind of a junior researcher, someone who needs a lot of mentorship, to being an independent investigator. Within the metaphor for this talk, I'd kind of liken it to culinary school. You can be a fantastic home chef, you can be a self-trained chef, but having that additional kind of formal training and support can kind of speed up your process and get you where you want to go. So as part of my K23 award, I also explored novel pre-hospital risk factors, specifically coming from a nursing home and taking an ambulance to the hospital for fragmented readmissions. And then I also looked at whether electronic information exchange might mitigate some of the negative outcomes that we do see in fragmented readmissions among older adults with Alzheimer's disease. So this slide really highlights where I am in my research career now. I'm in year 5 of my K-23, so it is winding down, but I'm actively expanding my research to explore other types of care fragmentation, including primary care fragmentation. So when a patient sees multiple PCPs, I'm sure you residents have seen that more than once in your primary care clinics and have encountered some of the challenges with that. And then I've also been working with Jen Lom on looking at urban hospital closures. You might not think of hospital closures and fragmented care as being of a piece, but what happens when your hospital closes? You got to go somewhere else for care, right? And so you're kind of forced to have fragmented care. We have an EMCF grant to actually look at the effects of the AMC closure on patients in the Atlanta area from this through this fragmented care lens. And I also continue to explore my interest in health information technology. I'm developing projects examining patient portal and open notes use, specifically in older adults, as well as advancing my research into health information exchanges and kind of how we can move this field forward into reflecting kind of more the reality of how health information exchanges are used in clinical medicine. And I'll also mention that, forging new grounds also requires looking at new populations and developing new collaborations. So this map, it's a little bit old, but it's a map of existing all-payer claims databases and all-payer claims databases in development. In case you're not familiar, an all-payer claims database is basically exactly what it sounds like. It's a data set of all claims in a state from all payers, so private, federal, it doesn't include uninsured, obviously, which is a gap. But I've been fortunate to collaborate with the Texas All-Payer Claims Database on a project investigating health disparities in patients who get their primary care at urgent cares compared to patients who get primary care in traditional primary care settings. And then I also support the Georgia All-Payer Claims Database in their operations. And then also, just to kind of go back to my point about looking for inspiration across multiple sources, this project was actually inspired by a conversation that I had with Rick Goodman, one of my other mentors, about a New York Times article that came out a couple years ago about the explosion of urgent cares in New York City and how patients were seeking primary care there. I'm also looking at incorporating new populations into my research. This picture of me in front of the poster is from Academy Health Conference last year, a paper I did with Mo Ali and several other Emory researchers on diabetes hospitalizations that actually won an award for best paper. And then I'm excited to continue to work with awesome researchers here at Emory, including Ade and Rachel. And then outside of Emory, this is Stephanie Nothel. She's a colleague at Hopkins. And then I was asked to collaborate with the Office of the National Coordinator for Health Information Technology, which is now called the Assistant Secretary for Technology Policy, as a direct result of my work on health information exchanges. And of course, the final and probably most important ingredient is your support system outside of work. I've received so much support and encouragement from the folks in these pictures over the years. I cannot tell you their impact. And here's some pictures of my family. And no matter what happens in research and in my career or in y'all's careers, just remember that family and friends are the most important people in your life. So, I wanted to summarize some of the lessons that I feel like I've learned, and I hope that I've illustrated their importance to you all today. So first, don't be afraid to pivot. If the path you're going down doesn't feel right, don't be scared to try a different one. Second, look for inspiration from many sources. As I described, I've been inspired by patients, colleagues, random things I've read. Look all around you for research ideas. Next, surround yourself with excellent people, both at work and outside of it. Additionally, you do have to have a thick skin and persevere. Remember that talks like these are a highlight reel of successes, but I could give a talk twice as long or longer about things that didn't work out. And so just remember, research is tough, persevere, it will be worth it. And finally, research is just one part of a career, but it can generate a lot of new opportunities for you. I don't have time today to talk about all of the other things in my career that research has brought me, including opportunities in medical education, getting to serve on study sections, national service opportunities, and the list goes on. But the impact of research on your career does not end when that paper is published. And so you really want to leverage, all the work you're doing and maximize its impact for yourself. And so with that, I'm done, and I'm looking forward to questions at the end. And I will turn it over to our next speaker. Thank you guys so much.
Thank you for the fantastic talk, Dr. Turbow. Next, we will have our 2 original research and 1 clinical vignette resident presenters. Their abstracts were chosen in a competitive, blinded review process from over 100 submissions this year. A big congratulations for our 3 chosen speakers. Our first resident speaker for original research is Dr. Katie Sharma. Dr. Sharma completed her medical school training at Emory University School of Medicine. She is currently a second-year resident in the primary care track. Today, she is presenting her work on the reevaluation of historical penicillin allergies, entitled "The Pen Fast is Mightier Than the Sword, Evaluating the Oral Amoxicillin Challenge at Emory University Hospitals." Our next resident speaker for original research is Dr. Ishwar Chuckaree. Dr. Chuckaree completed his medical school training at the University of Texas Southwestern Medical Center at Dallas. He is currently a second-year resident in the categorical track. Today, he is presenting his work on inflammatory markers in cardiovascular disease, entitled "Plasminogen Activator Urokinase Receptor Levels Are a Predictor of Adverse Cardiovascular Outcomes in the General Population, Independent of High-Sensitive CRP." And finally, our last resident speaker is Dr. Navila Sharif. Dr. Sharif completed her medical school training at the University of Tennessee Health Science Center, College of Medicine. She is currently a third-year resident in the categorical track and will be heading to Vanderbilt University following graduation for a position in their section of hospital medicine. Today, she is presenting her clinical vignette, "1 lumen, 2 zebras, nocardia and non-TB mycobacterium bacteremia in an immunocompetent patient on TPN."
Hello, everyone. I'm Katie. Thank you for the opportunity to speak to you today. You've likely have asked the question, do you have any allergies to medications? And some of you may have asked it this morning. A common response from 32 million Americans is penicillin. When we inquire more, we hear from the patient, "Oh, my mom told me I got a rash as a child after I got the medication." It's estimated that 32 million Americans have reported allergies to beta-lactam penicillins, but clinically significant IgE-mediated or T lymphocyte-mediated penicillin hypersensitivity is uncommon. For patients' allergy history that does not include a blistering rash like Stevens-Johnson syndrome, hemolytic anemia, or other signs of organ involvement, it's prudent to evaluate them for a true allergy. And that's because studies have shown the most common reaction is a delayed benign rash and may or may not reoccur. An IgE-mediated penicillin allergy wanes over time, with 80% becoming tolerant after a decade. And it may not have been a true drug reaction to begin with. For those folks with a rash as a child, it was more likely the result of an infection-related exanthem or a drug infection reaction rather than a true immunologic response to the antibiotic. Studies have shown that more than 95% of patients labeled as having a penicillin allergy can tolerate this class of drugs. The figure on the right helps us distinguish different types of cutaneous drug reactions. So on the left side of the figure, you have IgE-mediated reactions where the onset is within minutes to hours of the treatment when it's raised off the skin and is pruritic. In the middle, you have benign T-cell mediated reaction where there's onset days into the treatment course, typically less pruritic, and has a fine desquamation with resolution over days to weeks. And then finally, the image on the right represents the severe T-cell mediated reactions or severe cutaneous adverse reactions like Stevens-Johnson's. Onset is days to weeks into the treatment course. There's a blistering rash and mucosal or organ involvement, and typically requires hospitalization. So why does this matter to us? Well, reported penicillin allergies leads to the potentially unnecessary use of broad-spectrum antibiotics, which increases the risk of developing more antimicrobial resistance. As you can see from these headlines here on the slide, the threat of superbugs is definitely keeping somebody up at night. In addition, the use of these broader spectrum antibiotics leads to higher rates of C. diff infections and is more costly for the patient and our system. So what can be done about it? Formal allergy testing, like the skin prick test you see here, exist, but are labor intensive and require specialist interpretation. And as I mentioned, there's more than 32 million people with this reported allergy, which is far too burdensome for these types of programs. There needs to be a tool, something that I could use as a non-allergist in the hospital at the point of care that would help assess whether a penicillin allergy is a true allergy and if I could safely prescribe beta-lactam antibiotics. Luckily, there is a tool. So I'd like to introduce you to the PENFAST penicillin allergy clinical decision rule. This tool was developed to help guide risk stratification and direct appropriate delabeling of penicillin allergies and then prescribing strategies. This diagnostic study included a multi-center prospective cohort of 600 patients in Australia and was used to derive and internally validate the tool. External validation was then performed in a retrospective study of 1,000 patients at 2 sites, including one at Vanderbilt. The study showed that there were 4 features associated with a positive penicillin allergy test, and the features are listed here. So 5 or fewer, the reaction occurred 5 or fewer years ago. There was anaphylaxis or angioedema, a severe cutaneous adverse reaction, or that treatment was required for the allergy episode. As you see here, the tool allows us to assign points based on the allergy history to determine if a patient has a high or low risk of having a positive penicillin allergy test. And it was shown to be a practical tool with a high negative predictive value of 96.3% that uses the penicillin allergy history to identify low risk allergies with a score less than 3. So essentially a score less than 3 excludes a severe allergy. So for these patients with a score less than 3, they could then be challenged with 1 dose of amoxicillin and monitored for any reaction. If passed, then they could safely receive a beta-lactam antibiotic and is assumed to not have a true allergy. So we were in Australia and then we were at Vanderbilt, and that brings us to Emory University Hospital. The PENFAST clinical decision rule was implemented at EUH or all the Emory University hospitals by one of our pharmacists, Kristen Paciullo, and the Committee for Antimicrobial Stewardship at Emory. And this rule, along with the amoxicillin oral challenge order set, went live in EPIC in 2023. Fast forward to May 2024, near the end of my PGY1 year, when during my time on inpatient wards, I had a patient with a documented penicillin allergy who would benefit from an oral beta-lactam at discharge. It was suggested by ID consultant and steward of antimicrobials, Sujit Suchindran, that we use the PENFAST clinical decision rule and the amoxicillin oral challenge to assess her allergy. We did so, and we were able to remove her penicillin allergy from the chart and safely send her home on Augmentin. Well, this piqued my curiosity about the order set, and I asked him if anybody had looked into the data thus far, and he said that no one had. And there, my research project was born in the windowless room at the Gambrell team room to determine the safety and efficacy of delabeling penicillin allergies at UH. So for patients who have a penicillin allergy in the chart, but you'd like to prescribe a penicillin antibiotic, you can use the PENFAST tool and order set, which I'll walk through now. The text in purple gives instructions to the ordering provider and is shown alongside the PENFAST tool. After determining their score from the patient's history and deciding it's appropriate to move forward, the provider should obtain informed consent from the patient and make sure they know to notify the nurse if they develop any symptoms after receiving the medication. You should also let nursing know that you plan to do this and make sure they're involved due to the time and monitoring requirement. And the hypersensitivity protocol should also be ordered. You see here the order set includes the nursing interventions that are in place. And then if the patient has a score less than 3, you may proceed with the one-step challenge, which is 1 dose of 500 milligrams of amoxicillin, followed by monitoring by the nurse for 1 hour to assess for any reaction. There's also a 2-step or graded challenge, and this is for patients with a PENFAST score equal to 3 and involves 1 dose of 50 milligrams, and if well tolerated, a full dose of 500 milligrams with appropriate monitoring. At the completion of the oral challenge, there's more instructions here. So first, regardless of the result, you should let the patient know the result. Say you had a reaction, we'll keep your allergy on the chart, or you had no reaction, we can remove your penicillin allergy from the chart and you can receive these medications. So after letting the patient know, then we would like you to update the allergy in EPIC based on the results of the oral challenge. So if there's no reaction, remove the allergy from the chart and also make a note in the comments section of the allergy. If there's an allergic reaction that does occur, note it in the comments section of the allergy, saying that they did not tolerate the challenge. And if the patient has some other reaction like nausea, you can note it in the section as a side effect rather than an allergy. So I looked at all the data in which the amoxicillin oral challenge was ordered. Over 1 year from November 2023 to November 2024, there were 53 instances in which the PENFAST clinical decision rule and the amoxicillin oral challenge order set was utilized. It was used across 6 different sites you can see listed here, with the majority occurring here at Emory University Hospital on Clifton Road. And 94% involved in ID consults, and 6%, which was 2 cases, were rogue internal medicine and OMFS teams. So for the results of the challenge, these are categories that I assigned to the data myself. So from left to right, of the 53, 4 were considered failed, which I'll go into more detail shortly. The next 2 bars represent the total challenges that were passed. You'll see in the middle that 30 out of 53 had the allergy removed from the chart per protocol. But interestingly, I found in that second bar, 17 patients passed, but the allergy was not removed from the chart. 11 of the 17 had a comment in the allergy section that said they passed the amoxicillin oral challenge, and the remaining 6 did not note it in the allergy section, but there was documentation elsewhere in the chart that they passed the challenge. It's unclear why the allergies weren't removed according to the instructions in the order set, but is an area for future study. And then finally, those 2 last bars are one for a patient who declined the test after it was ordered, and then one patient who passed, but had probably 6 or 7 different penicillin-like allergies in the allergy section. So 1 was removed, but the rest remained. This pie chart summarizes the results based on the reaction observation. And you can see that among 91% of the amoxicillin oral challenges, no significant reaction was observed. And for the chart here on the right, which you can't fully see, this just describes the different reactions that people who failed the challenge had, which were symptoms such as nausea, vomiting, tingling in the mucosal surfaces, as well as rash and headache. For these instances, the allergy remained on the chart. So my takeaways from my research project are that the amoxicillin oral challenge is safe in our population. And utilizing the PENFAST clinical decision tool at Emory, along with the order set, can result in delabeling of up to 91% of patients with low risk features of the penicillin allergy. And this is in line with the literature that shows more than 95% of patients labeled as having a penicillin allergy are able to tolerate this class of medications. And as I mentioned, an area of future study is to look at the instances in which the challenge was passed, but the allergy was not removed, and what, if anything, we could do to standardize the process. And so you can join me and the other rogue internists and our ID and pharmacy colleagues to delabel penicillin allergies in patients with a low risk history who you want to safely prescribe a penicillin antibiotic. And if this presentation has taught you anything, I hope that it's not very rogue at all, and it is part of our roles as physicians and stewards of antimicrobials. I want to give a special thanks to Dr. Suchendran, Julian Gentz, and Kristen Pachulo for your mentorship and support in this project. These are my references. Thank you very much.
All right, good afternoon, everyone. My name is Ishwar Chuckaree. I also go by Ish. And today I will be giving a talk on our research, plasminogen activator urokinase receptor levels, or PLOWER levels, are a predictor of adverse cardiovascular outcomes in the general population, independent of high sensitivity CRP levels. I'd first like to thank our research mentor, Dr. Kayumi, as well as the rest of the medical research team. This was a very collaborative effort. So let's jump into some background. So depicted on the right here is the atherosclerotic process. And before you tune me out, I promise I'm not gonna go in extensive detail about this, but essentially inflammation is a known driver of atherosclerosis. Atherosclerosis, which eventually leads to coronary artery disease, which eventually leads to adverse cardiovascular outcomes. So inflammation can be assessed clinically through biomarkers such as ESR, CRP, ProCal, which we all use in the clinical setting, among other inflammatory biomarkers not listed here. But CRP specifically has been well studied both in CAD patients and in the general population for adverse cardiovascular outcomes. So it's found to be associated with coronary artery disease in the general population, as well as CAD severity in those with known disease. And it's also associated with myocardial infarction, stroke, cardiac mortality, and all-cause mortality in both of these populations. So this graph depicts a very generalized trend of CRP over time when an inflammatory stimulus occurs. So CRP, as you can see, rapidly increases during inflammation and quickly declines after the inflammatory stimulus is removed. So CRP levels fluctuate acutely to changes in the inflammatory state. Thus, CRP levels may potentially be less reliable as a marker for chronic inflammation. And there are other inflammatory biomarkers that fluctuate less in the acute setting and remain elevated for more prolonged periods of time. And one such biomarker is PLOWER. So that leads us to our study. So what exactly is PLOWER? PLOWER stands for the plasminogen activator urokinase receptor. It's also known as UPAR. And PLOWER is a cell membrane protein that is located on immune cells, endothelial cells, fibroblasts, and vascular smooth muscle cells. And during inflammation, PLOWER is cleaved to the SUPAR, which is basically the soluble form of the receptor in the bloodstream. And SUPAR further potentiates the inflammatory process. There are certain genetic variants of the PLOWER gene that are associated with higher PLOWER protein levels. And as I mentioned before, elevated PLOWER levels remain stable despite acute changes in the inflammatory state, unlike many other current markers of inflammation. So this characteristic of PLOWER potentially makes it a more reliable inflammatory biomarker. So this brings us to the objective of our study. So it was to investigate the predictive value of PLOWER for incident cardiovascular outcomes in the general population. Our primary outcome was incident cardiovascular death and non-fatal MI, and our secondary outcome was all-cause mortality. So patients were studied from the UK Biobank, which is a large prospective cohort of about 500,000 individuals aged 40 to 69 years old that were recruited from 2006 to 2010 and followed longitudinally. And compared to the general population of the UK biobank patients specifically tend to be older, more female predominant, and of higher socioeconomic status. And so the methods of our study, so of the 500,000 patients in the UK biobank, just over 40,000 had flour levels measured, and these were patients that did not have any known ASCVD or heart failure history. And we measured the occurrence of MI, cardiovascular mortality, and all-cause mortality, as I mentioned, during a median 14-year follow-up period. So these are outcomes again. They were all adjusted for several risk factors, including age, sex, race, HDL, LDL, triglyceride levels, BMI, hypertension, type 2 diabetes, smoking history, and use of hypertension and hyperlipidemia medications. And proportional hazards models were used to analyze the hazard ratios. So let's jump into the results. So table 1 here shows the demographic of our patient cohort. The mean age was 58 years with a standard deviation of 8 years. 55% were women and 94% were white. And our incidence of our outcomes was 7.9% MI, 2.7% cardiovascular death, and 9.5% all-cause mortality. So this graph here compares the cumulative incidence of our primary outcome, that being cardiovascular mortality and non-fatal MI, which you can see on the y-axis. And it compares this outcome between patients with flour values above the mean versus below the mean over a 7-year follow-up, as you can see on the x-axis. And this data is unadjusted for risk factors that I mentioned earlier. So as you can see here, the curves separate within a year. The hazard ratio is 1.91 with a statistically significant p-value of less than 0.001. So this demonstrates here that elevated flour levels are significantly associated with adverse cardiovascular outcomes and confers almost double the risk, as you can see. So how are these results affected when we correct for risk factors? So this table here highlights the primary and secondary outcome hazard ratios for every standard deviation increase in flour. It also shows how the hazard ratio, changes when correcting for risk factors and CRP. So in column 1 with the unadjusted model, this is just the unadjusted data. In column 2, model 1 is corrected for risk factors. And in column 3, model 2 is corrected for cardiac risk factors and high sensitivity CRP levels. And as you can see in column 3, after adjusting for both cardiac risk factors and CRP levels, the flour levels did remain predictive of adverse events with double the risk for the primary outcome and over triple the risk for the secondary outcome, both with significant p-values less than 0.001. So this basically then demonstrates that elevated flour levels are associated with adverse cardiovascular outcomes, even after correcting for risk factors and CRP levels. So next up, how does addition of flour to a cardiac risk model affect its ability to predict outcomes? So in this table here, we show the C statistic that corresponds to each cardiac risk predictive model. So model 1 is essentially a model based on the cardiac risk factors I mentioned. Model 2 adds on high sensitivity CRP, and model 3 adds on flour to help with prediction of adverse cardiovascular outcomes. So now you might ask, what is a C statistic? And it essentially stands for concordance statistic. And it's essentially a metric of how well a model predicts what it is meant to predict. And C statistics range from 0.5 to 1. And a model of 0.5 is essentially no better than random chance. And a model that has a C statistic of 1 is essentially a perfectly predictive model. So as you can see here, the C statistic improves with each model. And eventually when you get to model 3, you see that the addition of flour improves the ability to predict and prognosticate adverse cardiovascular outcomes, even after adding on CRP. So now we know elevated flour is associated with our adverse cardiovascular outcomes, and that flour is additive to CRP and predicting cardiovascular outcomes. So the next thing we looked at was analyzing the interaction between flour and CRP. So this graph here, again, like the first graph I showed, compares the cumulative incidence of our primary outcome, that being cardiovascular mortality and non-fatal MI on the y-axis. And it compares patients with both low and high flour and CRP over a 7-year follow-up on the x-axis. And so the curves essentially represent, in green, you have patients with essentially low flour and low CRP levels. The blue patients have only high CRP levels. The purple patients have only high flour levels. And then the red patients have both high flour and high CRP levels. And so the first thing you can notice here is that all the curves are statistically significant from the baseline green curve, which means that they do have significantly increased risk for adverse cardiovascular outcomes. Notably, when you look at patients with only high CRP in blue and only high flour in purple, they both have significantly elevated cardiovascular risk. And then what's even more interesting is when you look at the red curve, patients with both high flour and high CRP, these patients have the highest risk with a hazard ratio of 2.63, so over double that of the baseline patients in green who do not have elevated flour nor elevated CRP levels. The other thing to note is that the confidence interval of the red curve does not overlap with any of the other curves. So I think this graph sums up 3 key things. One is that elevated flour predicts adverse cardiovascular outcomes, as you can see with the purple curve. Is additive to CRP in predicting adverse cardiovascular outcome. In the general population, and is independent and additive to traditional risk factors and high sensitivity CRP levels. Flour is also a stronger predictor of cardiovascular adverse events in women compared to men. So what's next in the future? So flour may help us with cardiovascular risk stratification and prognostication in the clinical setting. Flour may help us bridge cardiovascular outcome disparities between men and women due to its stronger predictive value in women. Future research into sex-based flour differences may help reveal useful knowledge to us. And then lastly, I think future therapies may potentially be able to target the flour gene expression pathway. So
on this case that I saw about 2 years ago at the end of my intern year with Dr. Masser while I was here on UH Words for the first time. Okay, so jumping right into it, we have a 37-year-old female who has a history of multiple GI conditions, including malnutrition secondary to short gut syndrome. She is TPN dependent for the past 2 years and currently has a Hickman catheter in place, which was last changed about 8 months prior to presentation here. She is coming in with about a week of fever, malaise, and pleuritic chest pain, along with more acute onset of nausea, vomiting, and epigastric pain. In terms of further history, for her home medications, she is on some nausea and pain medicines. She is from Georgia, lives with her family, including her 2 kids, neither of which go to daycare or were recently sick. She has not had any recent environmental exposures, no travel, no hiking, no interesting ID stuff. But she has had multiple prior hospitalizations, including for episodes of bacteremia with Klebsiella, Candida glabrata, and Bacillus species. So on initial presentation, her vitals were significant for a Tmax of 39.6, tachycardia to the 120s, had a soft blood pressure, hundreds over 60s, a normal respiratory rate, and a normal SpO2 on room air. On exam, she had visible rigors, a normal cardiac exam. Her lung exam revealed crackles at the bilateral basis. Her abdomen was tender in the right upper and epigastric regions. The Hickman catheter looked okay. There was no tenderness, no erythema, or surrounding warmth. In terms of labs, the patient was significantly pancytopenic with a white count of 2.9, hemoglobin of 5, and platelets of 60,000, none of which were her baseline. The CMP was unremarkable, including creatinine and LFTs. She had an elevated procal, interestingly, a normal lactate, had an elevated LDH and D-dimer. DIC labs were checked in the setting of pancytopenia. Blood cultures were drawn both from the central line as well as from 2 peripheral cultures. Quickly, the central line grew gram-positive bacilli. The other cultures remained negative, at least at the 48-hour mark. We did quite a bit of ID workup with the help of our ID colleagues, which included HIV, hepatitis serologies, and then the listed labs here, all of which were unremarkable. In terms of imaging, we started with a CT chest, which showed ground glass opacities and nodular consolidations, pretty diffusely, but more prominent in the left lower and right middle lobes, which per the read could represent multifocal pneumonia or septic emboli. She also had abdominal imaging, which was notable for hepatosplenomegaly. So now thinking about this in terms of problem representation, we have a young patient who is TPN dependent, has a line in place, coming in septic with consolidations on imaging, and now gram-positive bacilli bacteremia. At this point, our differential was broad, especially because she had no clear exposures that we could really think of. She certainly had risk factors for fungal infections. We considered some of the following, including Listeria, Actinomyces, maybe TB or some other mycobacterium, and really any other atypicals that you can think of. So around day 4 or 5, we were still treating her with broad spectrum antibiotics when I got this text from our ID colleagues with a very pretty picture, but that's all I kind of knew about it. And, you know, thankfully they were on board to help with the rest. But what we have here is after about 72 hours, this was going from gram-positive bacilli to a more descriptive beaded and branching. And ultimately that speciated to a Nocardia species, being Africana/Nova. So we'll talk about Nocardia a little bit. It is a partially acid-fast gram-positive bacilli. Generally, you think about coming from the soil, so asked about all those exposures, which did not exist for our patient. Generally, it causes pulmonary infection. Ground glass opacities and nodular consolidations are quite common and pretty classic for pulmonary nocardiosis. In terms of nocardia bacteremia, that is a bit more rare and associated with high mortality. Typically, it occurs in patients who are considered classically immunocompromised, so are patients with HIV, long-term steroids, transplant history, which didn't exactly fit our cases here. Then back to our patient, we're treating her for nocardiosis at this point. And now we're at day 10 when we get a call from the microlab that there's something else growing on the same initial cultures. Now this picture is from Google, so I can't take any type of credit. But this speciates to Mycobacterium fortuitum. So now we have essentially 2 rare bacteremic species. In terms of this one, is a rapidly growing non-tuberculosis mycobacteria, also found in soil and water. Normally causes either skin and soft tissue infections or pulmonary infections. But for the pulmonary infections, it tends to be in patients who have some pre-existing lung condition, whether that's TB, interstitial lung disease, lung cancer. It can be associated with line infections, which is what we suspected in this case because it can form biofilms. So there was quite a bit of wait when we were waiting for the final culture. So that essentially took about 4 weeks. You can look at this from the timeline, and the patient was inpatient this entire time for about a month. Going through the summary of her hospital course, she was initially on empiric antibiotics with 5 drugs, including fungal coverage. We had initially done vancomycin, but then switched to cefepime because of thrombocytopenia. She's also on azithro and flagyl and micafungin. Her central line was removed as the suspected source, and she was started on treatment for nocardia with dual therapy, IV Bactrim and linezolid. Her blood cultures did clear, and ultimately she got another line placed after 10 days of clearance. She received some further workup in order to figure out where this was coming from and whether or not it was metastatic. Got a bronch with BAL, which was negative, but that was collected after several days of being on antibiotics. Also got a cardiac workup and an MRI brain, which were all unremarkable. Ultimately, this patient did really well. She was, like I said, inpatient for about a month, and then she was discharged on 3 to 6 months of IV Bactrim and imipenem with IV follow-up for the ultimate course. My takeaways from this case were that the term immunocompromised is not exactly binary, and it can include patients with significant healthcare exposures, our patient being on TPN, having a central line, which certainly provides a direct portal of entry, and so we suspect that's what happened in this case. Both of these were atypical organisms that were suspected to be from the line. We treated them as true infections given how sick she was. We also learned that it can take several weeks to get a final answer and to get a course of antibiotics, like a decision on that. In terms of nocardia specifically, it's important to consider sources and to get a bronch, usually a TTE plus or minus a TEE, and also an MRI brain because of the propensity for CNS spread, whether or not the patient has any neuro symptoms. And then nocardia plus NTM bacteremia is not seen often, but both can be seen with central line associated infections. So it's something to keep in mind for our patients, even in the outpatient setting who have lines in place and they come in. So that's basically what I have. Thank you.
Awesome. Thanks so much to all of our great presenters. I'm going to welcome, I know we're kind of at the top of the hour, but we have a couple minutes to ask some questions. We can either, people can kind of raise their hands over Zoom, or let me open up the chat here to see if there's any that have been sitting here. And we'll just have our speakers come up if they were addressed. Let's see here. So
Lots of amazing.
Yes, great praise for all of our speakers. Question in the audience. Just to repeat the question for the audience, we were wondering about what are there any prompts that will lead the PenFast and amoxicillin challenge order set to come up to prompt that decision making?
Right now, there's not a prompt. You would have to look at the amoxicillin challenge order set to be able to see the PenFast tool there. And then also in the guidelines, like on the intranet, you can find information about the penicillin allergies, which I know you all have bookmarked and look at all the time. Yes, if you know about the penicillin allergy order, amoxicillin challenge order set, which you do know now. So you can, if you see penicillin allergy on the chart, then you can enter in amoxicillin challenge and all of the information that I showed will come up with the tool as well.
Okay, any other questions? Okay, there's a question from Dr. Higgins that I think is also for Dr. Sharma. Are there plans to expand the PenFast tools to our other hospital sites?
I am not 100% sure about this. I think I remember hearing Dr. Webster talk about it at the VA, but I don't know if it has been implemented yet. And then I'm not aware of anything at Grady yet.
Any other questions from the audience or from our colleagues on Zoom? And one more pregnant pause. Okay, and then oh wait, there's another question from Dr. Kobayatse. I think this is also for Dr. Sharma. Have you ever used the PRIST or RAST for the penicillin allergy lab? That might be a general question. I'm not sure. Many of us have done that, and probably wasn't part of the study that you were doing. Okay. Well, maybe with that, as respect for everyone's time, we'll conclude our grand rounds today. Thank you so much to our wonderful speakers for all the great talks. And this is just another reminder that our Resident Research Day continues this afternoon from 4 to 6 in the School of Medicine lobby for our poster session. Please come by and check out all the wonderful work that our residents have completed. And there'll also be some light refreshments. So thank you all very much.